Hello and welcome to this presentation on hypertension in poor Alabamians. This presentation is a collaborative effort between Ricardo Pites and Sandra Horace for the population-based nursing course at Jacksonville State University. In this presentation, we will discuss the problem of hypertension in Alabama, contributing factors, levels of prevention of disease, hypertension-related levels of prevention, a DNP-led initiative to prevent hypertension in poor Alabamians, the necessary leadership competencies for the advanced practice nurse, and measures of success. The problem of hypertension in Alabama. At 40.4%, Alabama has one of the highest prevalence rates of hypertension in the United States. Among the poorest Alabamians with household incomes of less than $15,000, this rate soars to 51.7%. Hypertension prevalence rates decrease with increasing income, showing a rate of only 39% for the households earning more than $50,000 per year. National prevalence rates of hypertension lie at only 30.9%, highlighting the unequal burden Alabamians carry in regards to hypertension. Contributing factors related to higher rates of hypertension in the southeastern United States consist of population characteristics, health disparities, and the quality of primary care. Population characteristics in relevance to hypertension prevalence rates. The problem of hypertension in the United States portrays a health inequality. That is, African Americans share a higher burden in regards to hypertension than Caucasians do. The United States Census Bureau estimates 26.8% of Alabamians to be of African American descent. This stands in stark contrast to the national rate of only 12.7%. Lower socioeconomic status is often blamed for health inequalities. However, Sampson and colleagues note, in the case of hypertension in the Southeast, socioeconomic status does not appear to play a role. Higher rates of obesity and diabetes, however, are associated with hypertension. According to the Centers for Disease Control and Prevention, 12.1% of Alabamians share diagnoses of diabetes compared to only 9.1% of the national population. Furthermore, the CDC notes staggering rates of being overweight and obese in Alabama. 71.2% of Alabamians fit into this category. Compared to the national rate of being overweight and obese, which lies at 65.2%, Alabamians outweigh, literally and figuratively speaking, the nation. Sampson and colleagues also found higher rates of non-adherence by primary care providers to established and recommended treatment guidelines related to the treatment of hypertension. Health disparities and hypertension. According to the United States Census Bureau, 12.7% of Alabamians have no health insurance. Lack of health insurance prevents many from receiving preventive care measures. The mostly rural makeup of Alabama makes access to primary care providers difficult for many, as the primary care provider to patient ratio is much lower in rural areas than in urban and suburban areas. Poverty is yet another problem Alabama residents have to deal with on a daily basis, as the poverty rate in Alabama lies at 18.8%. Significantly higher than the nation's rate of only 15.5%. Poverty is linked to nutritional habits that increase the likelihood of developing hypertension. Quality of primary care. Sampson and colleagues found higher rates of non-adherence by primary care providers to established and recommended treatment guidelines related to the treatment of hypertension, which leads to suboptimal treatment of this disease in Alabama. Let us now briefly discuss disease prevention models. There are 3 levels of preventing disease, although only one actually involves disease prevention. The others focus on preventing progression and debilitation from disease. Primary prevention alters susceptibility or reduces exposure to disease. It also includes health promotion. Secondary prevention includes the early detection and treatment of the disease. The goals are to either cure or slow progression of the disease. Tertiary prevention is implemented mid-progression or late in the progression of the disease and consists of measures to restore function and alleviate disability. Primary prevention related to hypertension. The Centers for Disease Control and Prevention note the presence of many behavioral patterns which lead to the development of hypertension. Many times behaviors are modifiable and the incidence of hypertension can be prevented. Therefore, behavior modification is considered a primary form of prevention. Behavioral risk factors related to hypertension are unhealthy diets, physical inactivity, obesity, too much alcohol, and the use of tobacco. Therefore, diet modification, exercise, smoking cessation, and the limited intake of alcohol can all be considered primary disease prevention methods in the battle against hypertension. Secondary measures in prevention of hypertension. The Joint National Committee's 8th panel published recommendations for medication management of hypertension following research and trials of the then current antihypertensive regimens. The algorithm itself is complex based on specific comorbidities and ethnic populations, but the general guidelines can be found in the notes section of this slide. Let us now briefly discuss this doctor and nursing practice-led initiative to combat hypertension in poor Alabamians. The initiative presented here is a mobile unit for hypertension prevention and treatment. This unit will consist of a doctor and nursing practice, a pharmacist, nutritionist, and a county health department nurse or other representative. Health fairs are a good means for patients to monitor their blood pressure and other indicators of health, but the idea here is to bring the treatment to the patient. Having a small selection of first-line drugs available and daily blood pressure logs for patients to monitor their blood pressure gives them the tools they need to begin managing their hypertension. The mobile unit for hypertension prevention and treatment. Nutrition counseling and lifestyle changes are important measures to be taken in the battle against hypertension. Cuyahoga County in Ohio, which includes the city of Cleveland, instituted a produce prescription program that gave vouchers to poor patients with hypertension. With these vouchers, they could obtain fresh produce at local farmers markets. Participants reported trying new fruits and vegetables, increasing intake of fresh produce, and decreasing the number of fast food meals eaten. Many poor Alabamians have access to the Supplemental Nutrition Assistance Program, or SNAP. Of the 1.8 million households in Alabama in 2016, nearly 400,000 were receiving SNAP assistance. Fresh produce is included in SNAP assistance. Therefore, education should be done regarding healthy food choices and which foods to avoid to help lower cholesterol. This strategy will only be effective if the patient adheres to the prescribed regimen and if they follow up. Information about county health department services should be available for patients who do not have a primary care provider. If the patient does have a primary care provider, follow-up is needed in order to monitor effectiveness. The mobile unit will offer follow-up. However, the goal is to have the patient become established with a primary care provider in their area so as to provide the consistency and monitoring needed for management of a chronic condition such as hypertension. The disciplines involved in this initiative will be a doctor and nursing practice, a pharmacist, a nutritionist, a county health department nurse or other representative, and a medical assistant as needed. Structure. This initiative is designed to be led by the doctor and nursing practice, who will organize and monitor the progress of this initiative. Furthermore, the DNP will engage community leaders and primary care providers. Also, the DNP is available to assess the patient's blood pressure and recommended treatment options in collaboration with the pharmacist. The pharmacist in this unit will recommend medications and dosage based on the patient's history and other contributing factors. The nutritionist will stress the importance of proper nutrition and lifestyle as a measure of treating or preventing hypertension. The nurse from the county health department can then offer information on services and availability to the patients so they may get established with a provider there, if they do not have a primary care provider. The county health department nurse can also reinforce what was said by the DNP, pharmacist, and nutritionist. The medical assistant will be responsible for patient sign-in, taking blood pressures, and handing out supplies along with other tasks assigned by the rest of the team. The importance of outreach and the creation of a continuum of care. Reaching out to community leaders and primary care providers is a must, as the presence of the mobile unit for hypertension prevention and treatment will not be an ever-present entity in communities. Primary care providers, community leaders, and local health departments hold a much more consistent presence in communities and must be tasked with keeping up the efforts initiated by the DNP-led initiative. The role of the DNP in outreach and the creation of a continuum of care. The DNP must engage community leaders, primary care providers, and local health departments. The role of community leaders. Community leaders can assist in providing space and needed resources, raise awareness, and assist with ensuring the greatest possible turnout and high numbers of attendees by advising program designers. The role of primary care providers. Primary care providers should be proactive in screening for hypertension as well as the presence of risk factors related to this health problems. Additionally, primary care providers should be diligent in treating this disease as effectively as possible. This includes appropriate pharmaceutical treatment and reevaluation of the client. Therefore, in order to accomplish therapeutic drug levels, i.e. levels that achieve normal tensive blood pressures, drug titration and/or addition of medications must follow at recommended intervals. Furthermore, client education is a must at every point of contact between clients and care providers. Local health departments can be tasked with engaging clients in hypertension screening, dietary education and provision of printed materials, referral to primary care providers, and the referral to agencies and programs assisting individuals with no health insurance. Let us now discuss leadership competencies. Leadership competencies are a set of competencies for nurse leaders set forth by the American Nurse Association Leadership Institute to build, enhance, and strengthen qualities of nurse leaders. There are three clusters of competencies: leading others, leading the organization, and leading yourself. First, leading others. Communication is an important competency for the DNP in this initiative. Collaboration across disciplines requires communicating ideas and information clearly. Second, leading the organization. Project management is a leadership competency necessary for the DNP. Organizing and prioritizing will be some of the primary roles of the DNP in this initiative, which are important qualities of leaders who demonstrate effective project management. Delegating and assisting those involved in the project are also needed. Lastly, leading yourself. Initiative is vital to the DNP in this role. Having initiative includes being determined, involved, and self-disciplined. Measures of success. Collaborative efforts to screen the community and identify those who have or are at risk for hypertension could prove to be a time and resource-consuming effort. It is important, therefore, to determine the effectiveness of such an intervention. Is this initiative having an effect on the community, and is it having an effect on the individual patients, are two important questions to ask when determining success of the intervention. The following slides discuss the measures of success for the community and then the individual respectively. Measures of success for the community. The number of patients who participate in this initiative is one indicator if it is successful. Especially in rural and low-income areas, word of mouth is an important means of communication. As participants share their experience with the mobile unit in their community, numbers will grow based on success. Simply because a patient does not return to the mobile unit does not mean they are not receiving care. Follow-up phone calls, emails, or letters can be used to determine if patients have become established with the provider to manage their hypertension. Monitoring how many patients have received follow-up care will assist in determining if other interventions are needed to assist patients. Measures of success in the individual. Monitoring the success of this intervention in the individuals has several measures. The daily blood pressure log should be assessed for trends in blood pressure, especially downward trends following the initiation of medication therapy. Reinforcement of the use of this log is also vital at every encounter. Assessing self-reported lifestyle changes and increase in perceived or actual wellness can be another measure used to determine success of this initiative. Although this is a subjective measure, it is still an important one. If patients notice a difference in their wellness for the better as a result of the intervention, they are more likely to adhere to it. Lifestyle changes are difficult to monitor without daily, even hourly patient contact, so this measure is also subjective but important, as lifestyle changes are a recommendation from the Joint National Committee for all hypertensive and prehypertensive patients. In summary, Alabama shares an unequal burden of the problem called hypertension in the United States. The reasons for this phenomenon are multifaceted but modifiable. Hypertension is, the majority of the time, a preventable disease whose occurrence hinges on the presence of behavioral risk factors. Due to the enormous prevalence of hypertension, the prevention and treatment of this disease is best addressed at the population level. Raising awareness and educating clients as well as primary care providers is a valid starting point in this endeavor. The creation and execution of a program aimed to address communities as a whole requires strong leadership skills, cultural awareness, and sensitivity, as well as initiative, or a strong drive to succeed and make a meaningful impact. Doctor and nursing practice educated, advanced practice registered nurses have a sufficient knowledge base to succeed in designing intervention strategies that address populations as a whole. Leaving populations with the necessary tools to continue on the path of progress is vital to achieve long-term goals and lasting effects. Outcome measures need to be evaluated at appropriate intervals to monitor for meaningful and lasting progress.